Good evening and welcome to the Epilepsy Foundation of Minnesota's Wellness Wednesday webinar series. My name is Debbie Leone and I am the Client Services Manager for EFMN. This webinar is being sponsored by Synovian and we thank them for their support. We're very excited tonight to be partnering with Dr. Julie Hanna of the Minnesota Epilepsy Group to present this webinar on epilepsy and aging. While EFMN is hosting this webinar, all content and discussion points are led and delivered by our guest speaker. The information shared is to inform you about various aspects of epilepsy and aging. However, specific concerns about your or a loved one's needs should be discussed directly with your medical provider. Before we get into the meat of the webinar, I want to just spend a few minutes talking about the programs and services that EFMN has to offer the epilepsy community. Right now, we're right in the middle of camp season, so we are taking registrations for our week-long summer camp, which is called Camp Oz. It's an overnight traditional camp program. We also offer a day camp, and that is for kids who maybe aren't quite ready for Camp Oz, but it helps them prepare for that overnight camp experience. And then we have a family camp for those with additional physical, social, or emotional needs. Our Connect groups are one of our most popular programs that we offer, and these are a monthly space where you can meet others who are on a similar epilepsy journey and share experiences, share support with your peers, and we offer these for 6 different specific audiences: adults with epilepsy, parents and caregivers of children with epilepsy, young adults, teens, parents with epilepsy, and then Spanish speakers. And then in addition to those monthly Connect groups, we also offer 2 groups that meet quarterly. One is for folks who have a rare or complex diagnosis, and another one for those who have lost a loved one to epilepsy. Our education services include this webinar series. It also includes things like seizure smart trainings that we do for schools, workplaces, social service organizations, and other types of audiences. Our client services team is working with individuals, caregivers, and professionals to provide information and resources on just a wide variety of epilepsy-related topics. And we do that through free one-on-one customized support. And I will talk a little bit more about that at the very end of the webinar as well. Our Shining Star program is for all youth with epilepsy under the age of 18, and it includes connection opportunities for youth, support services, or support resources, for families, as well as epilepsy awareness and education activities for families and communities. Social events is a really important part of what we do. These are opportunities for folks to get together with all kinds of people with epilepsy from various groups. And we just want to be able to have people connect, be able to share experiences, and to have some fun. This helps to fight some of the isolation that sometimes can happen along with an epilepsy diagnosis. And the events happen throughout the year, and they're planned on a regional basis to meet the needs of the local communities. Our advocacy program, we work to shape policy at the local and state level so that we can try to make a better, just a better place for people with epilepsy to live in Minnesota. And then finally, our donated goods program. And this is something that just helps us put all these other programs and services in place. Donations of household goods and clothing help us to fund our programs and services. And if you want information about how you can donate, you can go to our website to see where we offer free pickup services or where we have drop-off bins. These are just some of the events that we have coming up over the next month. It's a really busy month, and I'm not going to go through every one of them. I will say that our social events are very much about food. this coming month. We are doing taco and game nights in multiple communities around the state. We're doing pizza events and pizza parties in some of the other communities, as well as a snacks and conversation event in St. Paul. So if any of those interest you and they're in your area, we hope that you'll register and come out to join us at those. All of those connect groups that I talked about will be every single one of them will be meeting virtually over the next month or so, and the dates are on here. We also, our Shining Stars will have an opportunity to do a splash event at Arrowwood Resort in Alexandria, where they will be able to have fun at a water park. I will be sending out this PowerPoint, so if any of these interest you, you will be able to have this for your reference to go back and look. You can also find any of our events at our website at epilepsyfoundationmn.org/events. And we do encourage you to go there and register for anything that sounds interesting to you. A few housekeeping items before we get started. The webinar will be 1 hour and 15 minutes. We really want you to have a good experience, so we ask that you close any windows that might be using a lot of bandwidth, particularly things like streaming services, music applications, and that type of thing. You will be receiving a certificate of attendance via email within 3 business days from tonight, and that will come to you, as I said, through email and will be accompanied by the PowerPoint slides. And finally, we are recording this webinar, so that will be made available for anybody who wants to maybe watch it again, or if there are people who aren't able to attend, will be able to watch it. And that usually becomes available within about 3 weeks after the webinar itself. We really want to encourage you to ask questions tonight. Our speaker, we're fortunate to have a really knowledgeable speaker, and so if you have questions as the webinar goes on, please go down to the Q&A icon, which you should find at the bottom of your screen, and you can click on that. It will bring up a text box. You can type in your question and hit send, and those questions will be saved throughout the webinar and will be answered in a Q&A session at the end. But don't wait. Go ahead and type your questions in as you think of them, because we will be getting to those to answer them. I also want to let you know, when you ask those questions, our speaker is not going to be able to offer medical opinions or advice about you or your loved one's particular needs. So for that reason, and to respect everyone's privacy, we do ask that you keep your questions general in nature and not specific to any one individual situation. You can also use that Q&A box if you have any technical problems throughout the webinar. My colleague, Nikki Baker, is here behind the scenes, off camera, and she's going to be watching to try to help with any kind of technical problems that might arise. And then to avoid confusion, the chat feature has also been disabled. So if you need to communicate with us, please do that through that Q&A icon. Okay, I'm going to go through the objectives for tonight's webinar. They are to identify the special challenges in diagnosing and treating epilepsy in older adults, to explore the relationship between epilepsy and other neurological disorders in the senior population, to understand the emotional and psychosocial impact of epilepsy on seniors, and to anticipate what changes might be expected as those who were diagnosed as children or younger adults begin to age. So it's my pleasure now to introduce our speaker for this evening. Dr. Julie Hanna completed her undergraduate studies at Indiana University, receiving a Bachelor of Science in Biology and a Bachelor of Arts in French. She then attended medical school at Indiana University School of Medicine. Dr. Hanna completed her neurology residency at University of Minnesota before completing her neurophysiology fellowship at both the University of Minnesota and Minnesota Epilepsy Group. Dr. Hanna's areas of expertise and interest include care of women with epilepsy and tuberous sclerosis complex. Outside of medicine, Dr. Hanna enjoys spending time with her husband and 3 kids. She also enjoys visiting parks and museums, traveling, and attending concerts. Dr. Hanna appreciates the opportunity to support her patients through all points of their care. She's interested in working with her patients to help them reach their best possible seizure control and quality of life. She finds it very rewarding to get to know her patients, to support them through difficult times with their epilepsy, and to celebrate their successes with them. We are very fortunate to have her here tonight. And with that, I will turn things over to Dr. Hanna.
Okay, hello, everybody. I can't see you, but I know you're out there. And I look forward to hearing your questions later. But I'm very pleased to be here tonight, and thank you to Debbie and Nikki and Epilepsy Foundation for inviting me to speak tonight about a topic that really interests me. I have been practicing for 15 years now since I finished my fellowship, and not only have I always had a number of patients in the older age group, but being able to experience aging with my patients has been very, very educational for me as well. And I've learned a lot from my patients as time has passed in their lives. And I have patients all the way up into their late 90s. I think my oldest patient is 98, and I just really enjoy providing care for them. So Debbie laid out the objectives for tonight's talk, and I guess I will just go ahead and jump into it. So next slide, please. I will spend a lot of tonight's talk talking about epilepsy that starts, or seizures that start in older adults, but I definitely hang in there with me if you're somebody who was diagnosed when you were a little bit younger. Hang in there, because I'm going to circle back and loop everybody in before the end. But there's actually a lot of research and a lot of information about seizures that start in older adults. So at least the first part of the talk will be focused on that. Because first-time seizures and epilepsy are very common in older adults. And as we hear all the time, the population is aging, the baby boomers are getting older, and when we talk about older adults with epilepsy, usually we're talking about people 65 and older. So that's a growing group. But not only do we see new-onset seizures very frequently in this age group, but they can be harder to pick out. They can be harder to diagnose and to tease out from other common medical conditions in this age group. And there are very special considerations that come into play when we talk about treating seizures, treating epilepsy in people who are older adults. So I'll go into detail on that. Next slide, please. After age 65, individuals have about a 1% chance per year of developing epilepsy. And that's looking at all people 65 and older. But if you are a woman 65 and older, or if you are 65 and older and you're a Black American, your chances of developing epilepsy over 65 are even higher. Right now, based on CDC data, about 1 million adults 55 and older in the United States have active epilepsy. And that means that they either are taking a medication for epilepsy, or that they have had a seizure, or that they have had a seizure within the preceding 12 months. So that doesn't even count people who have maybe been able to wean off of medications in the past. Looking at all age groups, about 25% of new seizures happen after age 65. And right now, about 1 in 6 people in the US anyway is 65 or older. When we look at the big peaks of epilepsy onset, there's a big peak early in life, babies and school-age children. And then the rates are much lower for new onset epilepsy through, kind of early to middle adulthood. And then there's another peak in the older age group. So the risk goes up considerably for people who are between ages 65 and 69. There's about an 85 out of 100,000 risk of epilepsy, all the way up to people 80 and older have 159 out of 100,000 risk of epilepsy. So not only does it go up after age 65, but it keeps going up after that. And it's the third most common neurological disorder in older adults. Stroke and dementia are the top two, but epilepsy and seizures are, that is close behind. Next slide, please. This slide shows the age-specific prevalence and incidence of treated epilepsy. This is from the United Kingdom. So prevalence, that term means all people who have epilepsy, whether they've had it for 1 day or 1 year or 50 years, just the prevalence of epilepsy. And you can see in the bottom graph that it goes up considerably toward the right there after age 60, 65. Incidence, that's on the top of the graph, incidence means new diagnosis of epilepsy. So you see a big bump at the very front of that top graph, that's younger people, and then it's lower throughout the middle, and then again goes way up toward the right side of the graph on the top. And that has to do with new onset seizures, new onset epilepsy diagnoses. Okay, next slide, please. Seizures can look so many different ways, and this is true for all age groups, that, you know, if you have epilepsy or if you love somebody who has epilepsy, you probably know that when the general public thinks of seizures, they think of one thing, and that's a generalized tonic-clonic seizures, a generalized tonic-clonic seizure. But seizures have a wide spectrum of presentations, and they can be harder to pick out in older adults compared to younger people. And this is for a few reasons. Older adults with seizures are less likely to have an aura. So for example, sometimes people will have an aura or a warning at the very beginning of the seizure, and depending on where the seizure is coming from in the brain, it can be a variety of different things. It could be visual changes, it could be a feeling in their stomach, it could be a taste in their mouth or something that they hear, a change in their hearing. But for older adults, they're less likely to have any kind of a warning at the beginning of a seizure. They're also less likely to have generalized tonic-clonic seizure, or what we used to call grand mal seizures. They're less likely to have motor features or automatism. So when I say motor features, that would be like, for example, twitching of the face or jerking of the arm. Automatisms are automatic movements that happen to some people during their seizures, and that could be something like lip smacking or puffing their cheeks, or sometimes kind of rolling their fingers together or moving their hands that are not conscious but are just happening automatically. Those are less common in older adults with epilepsy. Seizures can just look like confusion, drowsiness, difficulty speaking, or decreased responsiveness. And a lot of other things can look like that too. So it can be hard to pick them out. You have to sometimes think of it, you know, medical providers have to think of it or be alert to seizures being a possibility, because in older adults, many different things can happen, and I'll talk about what some of those are. The other thing is that older adults may take longer to recover from their seizures, and you maybe have heard the term of the post-ictal period, and that's the period when the seizure is over, but there's still recovery, and the person who experienced the seizure is not quite back to baseline yet in terms of alertness or in terms of their ability to interact with other people. So that can take longer too in older adults. Next slide, please. Okay, so this, just to put some numbers to what I was saying about the differences between seizures in older adults and younger adults, that aura, that warning, is in only about a third to a half of elderly. That was the term used in this study. I prefer older adults, but fewer people compared to young adults, which was the younger age group, which was at least 2/3 would have some kind of a warning at beginning of their seizure. Just subtle confusion was much more common in elderly patients in this particular study. Young adults were more likely to have multiple phases of their seizures. And I think that ties in really closely with having an aura. Like maybe you have a warning and then you have some mouth movements and then you lose the ability to speak. And then maybe that goes on to tonic-clonic seizures or something like that, but different parts, maybe along a spectrum, but that could be picked out of a seizure, and that's less common. And then, like I said, generalized tonic-clonic seizures are less common in the older age group, but that post-ictal, that post-seizure sleepiness is more prominent and also can last longer. Next slide, please. In older adults, and I should clarify, most studies looking at epilepsy in older adults use age 65 as their kind of beginning of older age. So just for the purposes of studies. And so most of the data on my slides tonight is looking specifically at people 65 and older. And that is true for this data as well. So about 30% of the time in people 65 and older, when they have that very first seizure, it's status epilepticus. And status epilepticus means either one long seizure activity that is continuous for 5 minutes or longer, or more than one seizure within 30 minutes, but without a full return to baseline alertness and ability to interact between the seizures. So status epilepticus can also be convulsive, meaning like generalized tonic-clonic activity, or what we used to call grand mal activity. And that is easier to pick out. Usually in this age group, if somebody has convulsive status epilepticus, like tonic-clonic seizure that's prolonged, usually it's because a stroke has happened. But there's also non-convulsive status epilepticus, which we see quite a bit in older adults, and that can just look like drowsiness, confusion, total unresponsiveness, like somebody looking like they're just in a coma. That can be due to status epilepticus, difficulty speaking, or just slight kind of twitchiness. The longer status epilepticus goes on, the worse the outcome in terms of like eventual recovery or actual chances of mortality with it. Also, the older the individual is who experiences it, the worse the prognosis is. And if there are issues with oxygenation, which is more common with convulsive seizures or tonic-clonic seizures, that also is associated with a worse prognosis or worse recovery. So for people over 80 years old, status epilepticus has a high mortality. So it's definitely a neurologic emergency and something that we try to identify and also treat as soon as possible when it's happening. Next slide, please. Seizures can look like many other medical conditions, and many other medical conditions that we see a lot in older adults. So it can look a lot like syncope, which is our medical term for fainting. And when people faint, they can just kind of drop down, limp, or sometimes when people faint, they have stiffening or a couple of jerks with that. And so those things can look fairly similar. Seizures can also look like a transient ischemic attack. So TIA, sometimes people use the term mini stroke for that. And what it really refers to is an event that causes neurologic symptoms that could be weakness or trouble speaking or visual changes, depending on what part of the brain is involved, related to lack of blood flow to that part of the brain. But it's brief and not permanent. So it doesn't quite count as a stroke because the symptoms go away, and usually when we get a brain MRI, we don't see a stroke. So those things can look quite similar. Metabolic disturbances, for example, having a low glucose level or having a high sodium level can cause drowsiness, possibly some twitchiness, some confusion, which can also look like seizures. Transient global amnesia is a diagnosis that we see in adults, really adults of all ages, but including older adults, where for a period of time, the individual experiencing it is unable to really make new memories. And so they will seem confused, they will ask the same questions over and over again, and it can last for up to a few hours. Seizures can look like something called REM behavioral disorder, which is also called RBD, or sometimes abbreviated as RBD, which is a condition during which normally when we sleep and we have dreams, our brain is programmed to prevent us from acting out our dreams, right? Because we don't want to be running around or kicking or talking or rolling out of bed or injuring our bed partners. But people who have REM behavioral disorder will get a mismatch, and they will move around in their sleep, often when they're dreaming, in an uncontrolled way that can seem very violent, although they're completely unaware that they're doing it. So those movements that people don't remember and aren't in control of or awake for can sometimes look like seizures, or vice versa. Psychogenic disorders are psychologically based conditions that can look a lot like seizures. We see them in all age groups, including in people who also have epilepsy, but essentially they're movements that can mimic seizures that are occurring on a subconscious basis related to psychological factors, and can look a lot like seizures. And then finally, cardiac arrhythmia, so irregular heart rhythms, especially heart rhythms that are too slow and affect people's ability to remain alert and upright. Okay, yep, next slide. This is just a quick rundown, because one of the biggest questions we get asked as epilepsy doctors, especially in the hospital, seeing people in the emergency room, is it syncope, is it fainting, or is it seizure? And some of the indicators that can help us based on the symptoms the person experienced, and also if we have firsthand description, are that before fainting, people often feel kind of sweaty and nauseated, they look pale, and if their eyes are going to deviate anywhere, they usually go up. With seizures, it's much more common to have a unilateral symptom, like movement on one side only, whether that is stiffening or jerking, or sometimes those, like I mentioned, automatisms, hand movements can happen on one side. It is much more common to have, instead of pallor, like looking white or pale, to have cyanosis, which is looking kind of dusky or bluish. Loss of consciousness in fainting is usually brief, and usually when people faint, if they kind of faint down into a horizontal position more or less, and blood flow to the brain increases, they wake up pretty quickly. But with seizures, loss of awareness or loss of consciousness can be much longer. I mentioned earlier that sometimes when people faint, they have a few twitches or jerks, and that's true, but it's usually just a few. So if somebody has prolonged jerking of their arms and legs, it's much more likely to be seizure. Same with tongue biting, excessive oral secretion, so a lot of saliva coming out, confusion afterwards lasting for minutes, and a lot of like muscle aches afterward. That's much more likely to be seizure. And then that last one, the periorbital petechial hemorrhage, certainly does not happen in everybody who has seizures, but sometimes when people have tonic-clonic seizures, they will have really small kind of blood vessels break around their eyes and on their faces, and that really we would almost never see in fainting. Next slide, please. All right, so let's see. One thing that I wanted to kind of address is, or I'll address it as I go, is what may be epilepsy and what is normal aging. And this is a toughie, and we work hard to help answer these questions with our patients, and they can be very hard to answer. But please ask your doctors, or if you're a caregiver, ask your loved one's doctor these questions as they come up, but be prepared that they might be pretty tough to answer. But your physician should work with you to try to come up with answers if they can. Because a lot of people, as they age, they may feel like they're having memory problems, or that their memory is not as efficient as it used to be, or their cognition is not as efficient or quick as it used to be. As people age, they are more likely to have falls. Is it normal to fall frequently? Absolutely not. So falls absolutely should be addressed. A few falls might be normal in older age, but generally falls really deserve attention because they're risky. A little bit of confusion may be normal. A lot of confusion, definitely not normal. And then the other thing that we hear about a lot is sensory changes. And most of the sensory changes that I hear about, for my patients anyway, is like both feet or both legs or both hands sometimes. But the sensory changes that I would worry more about when it comes to the possibility of it being epilepsy related is, especially if it's one side. If you are experiencing sensory changes on one side of your body only, that's much more likely to be related to epilepsy. But neuropathy is also very common in this age group, and so people will sometimes have sensory loss in their feet or legs. However, I wouldn't really consider any significant memory problems, frequent falls, confusion, or sensory changes normal, but it may or may not be related to your epilepsy or epilepsy medications. Next slide, please. Okay, so when we meet somebody either in clinic or at the hospital who's coming in with an episode concerning for possible seizure, these are kind of the vital things that we try to find out, and the way that we evaluate a patient for possible seizure in this age group especially. So in neurology in general, and in this particular situation, it holds true. History, meaning the story of what happened, is the single most helpful thing that we can gather. It's the most helpful test, and it's free. So whenever we can, it's useful to get an eyewitness account of what happened. Whenever we can, if the person who experienced it is able to tell us how they were feeling beforehand or what they remember about it, what's the first thing they remember after. For example, did you wake up when your head hit the floor, or did you wake up in an ambulance 20 minutes later? Was there any kind of warning or any kind of aura involved? And sometimes, thinking about my patients in clinic, this is something that happens less commonly in hospital, but in the modern age, people have a lot of videos of events, and those are so helpful. So if you have a questionable event that is caught on a phone, your physician would probably be very interested to see it, because it's even better information than a description. So an EEG, so the electroencephalogram, in older adults with epilepsy, outside of a seizure happening, abnormalities are only seen about 25% of the time on a routine EEG. So like if you came into clinic and had an EEG, or even in the hospital, if you had an EEG that was 30 minutes long or an hour long, and a seizure did not happen during the EEG, there's just about a 1 in 4 chance that that any abnormality, seizure-related abnormality especially, would show up on that EEG. So when somebody's coming in with a first-time event concerning for seizure in the hospital, sometimes continuous EEG is done because it's higher yield for picking up subtle abnormalities. And also, if that person goes on to experience another episode in the hospital, then it can be picked up on EEG and more clearly diagnosed as being seizure or not seizure. Anybody coming into the hospital with a questionable seizure, first-time seizure, will also get a pretty big lab workup. So electrolytes, looking at, is the sodium normal? Is the kidney function normal? Is the magnesium normal? Liver function, calcium, drug levels for any, well, not any, but certain medications that people take, we check levels for. Certainly seizure medications, if it's somebody who's already on a seizure medication, and then certain other medications will follow levels too. Anybody who has a first-time seizure, suspected seizure, is likely to have a head CT, CAT scan done in the emergency department. But we also do recommend a brain MRI, which just gives much more detailed images of the brain. For a 20-year-old or 30-year-old coming in with a first-time seizure, we'll just get a regular brain MRI. For older adults, we're much more likely to want to get an MRI with contrast. So that's where they put the IV dye in, and that can help subtle abnormalities show up, but it's also really helpful in picking up tumors, for example, and sometimes it can help infections show up that are more likely to happen in this age group compared to younger people. An EKG to look at somebody's heart rhythm, and that only takes about a minute to do, although very often ongoing heart monitoring in the hospital, if somebody's admitted to the hospital, can be useful information. And then finally, lumbar puncture or spinal tap, where a sample of spinal fluid is removed. I would say that is not standard in the evaluation for a first-time seizure in older adults. But if there is suspicion of an infection and there's not another identified infection, such as a bladder infection or pneumonia, or if there's concern for an autoimmune process, which can happen in older adults, especially if there's cancer, sometimes we'll do a lumbar puncture too to add on some additional tests. Next slide, please. So the common causes of seizures in older adults are here. So cerebrovascular disease, and that would generally mean strokes, whether that's ischemic strokes where there's not enough blood flow to part of the brain, or a brain bleed or an intraparenchymal hemorrhage. So that's number one. Number two would be metabolic disturbances, high or low glucose, high or low sodium, that kind of thing. Dementia, and typically when we say dementia, that's the large majority of dementia is Alzheimer's dementia, but there's also frontotemporal dementia, vascular dementia, and other types that can be the causes of seizures. Traumatic brain injury, that can more easily in older adults lead to bleeding in the brain or around the outside of the brain. If you've heard of subdural hematoma, for example. Brain tumors are more common in this age group compared to younger people. And I'll talk about all of these in a little more detail. And then finally, medications, and that can be either medications that somebody's taking at the right amount, that they're taking too much of, or sometimes medications that have been stopped can cause seizures through withdrawal. When we think about why people have seizures, we're able to answer that question a lot more frequently in older adults compared to younger adults who develop epilepsy or who have a first-time seizure. Infants and children with epilepsy, we have a higher rate of identifying a cause, and sometimes that's genetic reasons or other early childhood medical conditions that we can identify a reason that they have epilepsy. For people who develop epilepsy in their 30s and 40s and really into their 50s, we often can't find any reason. For older adults with new onset seizures, we can find a reason in about 50% of these patients. But the other thing I tell my patients is you don't always want to know the reason that you're having seizures, because that means you're getting diagnosed with something else, and it's often something you would rather not have. Okay, next slide, please. So top cause of seizures in older adults is stroke, and acute or subacute. And an acute stroke would mean like a stroke that just happened or that happened within the past week, or a subacute stroke would mean a slightly older stroke. So about 1/3 to 1/2 of new onset epilepsy in older adults is attributable to strokes. And like I said, it could be ischemic strokes, hemorrhagic strokes, or also subarachnoid hemorrhage, which is a kind of bleeding that we see in people who have aneurysms, for example. The bigger the stroke is and the more cortex, which is the gray matter on the outside of the brain that's involved, the higher the risk of stroke. Also, strokes that involve bleeding are more likely to eventually lead to epilepsy compared to strokes that don't involve bleeding. Overall, for people who have strokes, 5 to 9% of them will go on to develop epilepsy. And the majority of the time that's going to show up in the first year, but risk doesn't go back to normal until 7 years after the stroke. The highest risk is right after the stroke. And for example, for embolic strokes, which is the kind of stroke where a blood clot travels up into the brain, there's a 16.6% chance of a seizure within those, first 2 weeks after that stroke type. Okay, next slide, please. Metabolic disturbances, they are a common cause of seizures in older adults, and a lot of that is because they have more going on medically, they have more diagnoses, and they're on more medications all the time. But the most common ones are to have low sodium or low glucose. However, high glucose, kidney failure, especially when it comes on suddenly, and liver failure can also cause seizures, although they're not necessarily more common in older adults compared to younger adults, but for sure low sodium and low glucose. And those can happen when people are on medications for diabetes, for example. They can unintentionally lead to low blood sugar, and sometimes medications for blood pressure, especially certain diuretics or water pills, can cause low sodiums. Okay, next slide, please. As I mentioned, dementia, primary neurodegenerative disorders, so like an underlying dementia or degenerative disorder are a major epilepsy risk factor in this age group. About 10% of people with Alzheimer's disease will develop epilepsy. And for people who have Alzheimer's disease or vascular dementia, the rates of epilepsy are 10 times higher than in other people. With Alzheimer's, a younger age of onset of the dementia and also more advanced Alzheimer's also increase the chance of having epilepsy with it. Next slide, please. Traumatic brain injuries. So in older adults, the biggest reason for traumatic brain injuries is falls. And subdural hematomas, which are blood collections between the brain and the skull, can happen more easily in older adults, even with minor trauma, even with no trauma. And part of the reason for that is that as people age, their volume of brain tissue gets smaller, and there are small veins that connect the linings of the brain, or the brain out to the linings of the brain, and they can tear more easily just because there's a little more space there compared to younger people. The other thing is that older adults are more likely to be on blood thinners for other diagnoses. So that could just be, aspirin potentially for stroke prevention, or it could be, Coumadin, warfarin, or other blood thinners to prevent clots in people who have had multiple strokes or have had blood clots in their legs or in their lungs or other places. Sometimes people are also on blood thinners if they have an irregular heart rhythm, like if you've heard of atrial fibrillation or AFib, that can be an indication for blood thinners too. So any fall, any injury can become a lot more serious when the blood can't clot in its normal way. So brain injuries are the cause for about 20% of new epilepsy in older adults. Next slide, please. Brain tumors. So 10 to 30% of new onset seizures in older adults. The most common brain tumors that we see as a cause for seizures, and really in general in this age group, are gliomas, and those come from brain cells themselves. And those can range from fairly benign ones, like grade 1 or 2 astrocytoma or oligoastrocytoma, all the way to the most malignant type of brain tumor, which is glioblastoma multiforme. Meningiomas, which are benign tumors that arise from the brain lining, and they can get quite big before they're detected. Or tumors that are metastatic tumors from another site, such as lung cancer or melanoma or kidney cancer occasionally, can spread to the brain. Seizures are more frequently seen with primary brain tumors, meaning gliomas or meningiomas, but compared to metastatic tumors from a different type of cancer. The other thing is that low-grade tumors, and when we say low-grade, that essentially means in this case slow-growing tumors, they cause more seizures than high-grade tumors such as glioblastoma, or they cause more. Low-grade tumors are less cancerous or less likely to be cancerous, and they also cause more seizures. The more cancerous tumors cause fewer seizures. But for people with brain tumors, a seizure is often how the brain tumor is diagnosed. They often don't have any other symptoms until that very first seizure happens, and that brings them to the emergency room where they have a scan done, and then we find it. Next slide, please. Thanks. Medications / drugs / withdrawal. So we use the term drugs for medications, but I just added it in separately because there's also illicit drugs or drugs of abuse. So up to 10% of new onset seizures in older adults. The higher the number of medications someone is on, the higher the risk that there's going to be a seizure or some other serious event related to their medications. In older adults, drug clearance can be slower, meaning their kidneys are less efficient at clearing the medication out, or maybe their liver is less efficient at processing medications. We know that older adults have a heightened sensitivity to the potential seizure side effect. And if you look at all of the package inserts for your medications, you would probably find seizure as a possible side effect on more than half of them. But older adults are just more likely to experience that rare side effect when it happens. Certain antibiotics make seizures more likely. Certain pain medications, such as tramadol, also called Ultram, also high-dose opioid medications. Certain antidepressants, such as bupropion, which is also called Wellbutrin. Certain other antidepressants make seizures more likely to happen, and also certain antipsychotic medications. The other thing that can happen is drug withdrawal. So sometimes we meet people with a first-time seizure who were taking Klonopin every day for a couple of years, or Xanax every day for a couple of years, and then it was stopped. Sometimes it was even lowered and kind of weaned, but still withdrawal seizures can happen with that class of medications. Alcohol intoxication doesn't cause seizures very often, but stopping alcohol for somebody who uses it daily and uses it in large amounts, especially, stopping alcohol can cause an alcohol withdrawal seizure. The other thing we know is that just having a history of an alcohol use disorder or a drug use disorder, even in remission, so even somebody who is in recovery and not using for months to years, they still have a higher chance of developing epilepsy when they're older. Next slide, please. All right, so how am I doing on time? I'm just going to gloss over this one, just that we know the cause of epilepsy in about half of older people, like I said, and stroke, dementia, tumors, trauma are the big ones. And then this is, I'm not gonna split hairs too much, but and I apologize for kind of melding these two together for anybody who's concerned about it, but there's single seizure and there's epilepsy, and some of you may have had this discussion with your physicians about when does it become epilepsy and what does the epilepsy diagnosis mean. And so in this study, they were just looking at acute symptomatic seizure, meaning one seizure that we could definitively trace back to something that happened at that moment, versus epilepsy diagnosis, which is typically 2 or more seizures or 1 seizure and associated EEG changes or structural abnormality. Next slide, please. All right, so how do we treat new onset seizures in older adults, and how do we treat seizures generally in older adults? We really have to look at people as individuals. And that's true in medical care in general, but I think even more so when we're thinking about treating seizures in older adults, because any kind of medication is going to have potential side effects or risks associated with it. But we also know that seizures have risks too, and so we got to strike the balance there. And the goal is seizure control, minimal side effects, and a normal lifestyle where you can do what you want to do and do what you normally do as much as possible. So when we think about medication choices, because medications are still the predominant treatment for seizures, how effective is it? How tolerable is it? What are the side effects? What are medication interactions for it? What other medical conditions does the person have? And how hard is this medication going to be to take? Like if it's a 4 times a day medication, is that going to be a reasonable request of this person to do? Next slide, please. For people who have long-standing epilepsy as they age, what can they expect? Seizure control is usually about the same as people age. I would say in older adulthood, it's usually about the same as in middle adulthood. For people who have catamenial patterns to their seizures, so that would be people who have periods and then have seizures either kind of before and during their period or sometimes associated with ovulation. Sometimes seizure control gets better after menopause. But we know that, that we as physicians taking care of people who have epilepsy need to anticipate changes in metabolism and changes in medication clearance. Like I said before, sometimes kidney function is not as efficient. Sometimes liver metabolism is not as fast as people get older. And physicians also need to be very aware of when people are starting new medications or adding on medications for other diagnoses, because those medication lists often do get longer as people get older. Another thing that we really have to be conscious of in older patients is bone health. And this specifically is something we need to think about in people who have long-standing epilepsy, because some seizure medications increase the risk for osteoporosis when they're used over time. And that includes many of the oldest seizure medications. Dilantin or phenytoin, that came on the market in 1938. And phenobarbital, primidone have been around for a long time. And for people who started taking medications in the 50s, 60s, 70s, really up through the 80s, for many people, that was Dilantin, that was Tegretol, that was phenobarbital, sometimes that was Depakote. And those all increase the risk for osteoporosis. And so people who were on those medications for a long time, or maybe still are, should be screened, really starting at a younger age, but for osteoporosis, in addition to having either extra calcium and vitamin D and or specific treatment for osteoporosis if that is a diagnosis for them. Next slide, please. One of the big challenges in older adults with epilepsy is just being aware of and managing polypharmacy. And when we say polypharmacy, that just means being on multiple medications, multiple prescription medications. And then a lot of people also take vitamins and supplements. So there are medications, there are many medications for other medical conditions that can affect seizure medications. They could make the levels go up, they could make the levels go down. Some seizure medications can affect medications for other things. So for example, I'm using generic names here, but carbamazepine, phenytoin, phenobarbital, mescaline, they can affect statins, which are used for cholesterol. They can affect some heart rhythm medications or blood pressure medications, steroids, immunosuppressants, and some chemotherapy drugs. So 8 out of 10 adults 65 or older has more than one chronic health condition, and often that amounts to multiple medications. And so I really think that the biggest thing is the physicians kind of being aware of it and communicating well with both the person taking the medications, but also with the other physicians who are part of the care team, and with pharmacists who are real experts and sometimes the real heroes in this situation because they're extremely alert to medication interactions. Next slide, please. Another thing that we have to think about is physiologic differences associated with aging. So as people get older, they have less protein circulating in their systems, and proteins often bind to seizure medications. And so that can just impact the amount of side effects and sometimes the efficacy of seizure medications. They may clear them out more slowly. The other thing is sometimes in older age, people have slower gut motility. So medications may move through your system more slowly. Constipation is a bigger issue, and there may be issues with actually absorbing the medications after you take them. The other thing is that there have been some really good studies done on patients in nursing homes where they had them on consistent seizure medications at consistent times, and they know that they were getting the medications, and then they checked the medication levels. And the levels fluctuated much more in older age groups than in younger age groups. And the question of why hasn't totally been answered, but the authors of this study felt that it possibly was related to absorption and gut function. Next slide, please. Side effects are twice as common in older adults with epilepsy compared to younger adults with epilepsy. So the biggest ones we hear about are ataxia or balance problems, tremor or shakiness, vision changes, and sedation or sleepiness. And we know that in the older population, there's already a higher risk for falls, and that those falls have a higher risk for bigger complications. So it's important to try to limit that issue, limit that risk with seizure medications in this population especially. We know that certain medications that we prescribe for seizures can cause low sodium. We know that certain medications we prescribe for seizures can cause cognitive slowing, word finding difficulty, memory difficulty. And I listed what those medications are, and certainly that's not true for every person taking these medications, but it is certainly true for some people taking them, especially when they're taking higher doses. The other thing is that certain seizure medications can cause changes in heart rhythms or heart electrical conduction in the heart. And they can also increase the risk of high cholesterol and peripheral artery disease or coronary artery disease with long-term use. And then we also think about psychiatric changes, because we know that many seizure medications, maybe some much more commonly than others, are likely to increase the risk of depression or anxiety or suicidality. Next slide, please. So how do we manage all this? Well, hopefully we manage it by like really paying attention as a provider, really paying attention to my patient's chart and medications, but also making sure that we're having time to talk through it all and understand, you know, how the person taking the medication is feeling. But generally, when it comes to seizure medications in older adults, we start at a lower dose than we do in younger people, and we increase the dose more slowly, and we do not aim for as high of a target dose for seizure medications. If it doesn't go well with the first med, we move on to the next thing. We know that extended release formulations may be more tolerable. We know that older and newer seizure medications both work, they're both effective. Sometimes newer ones have better tolerability. On the other hand, they're sometimes more expensive. Sometimes we have to start them out even slower. Next slide, please. So just I wanted to just mention again, medications are the mainstay of treatment for epilepsy. There are epilepsy surgeries, devices, and diets. I would say compared to younger people, the surgery, devices, and diets are much less commonly used and often much less feasible compared to in younger patients. Next slide, please. Cognitive concerns are very common among adults with epilepsy, and this is true for younger adults and older adults. They can be a variety of different cognitive concerns. We know that seizure frequency, medications, sleep, and mood can be big factors in cognition. If seizures are controlled, but somebody is still having a lot of cognitive concerns, medications are a common cause. Depression is also a common cause, but your physician may, if you have cognitive concerns, your physician may recommend formal cognitive testing, which is called neuropsychological testing, as it can be an early indicator of dementia. This kind of testing also provides a baseline, so it could be repeated, you know, years later for comparison. Physicians may also look at drug levels, but also we know that anxiety and depression are more common among people who have epilepsy compared to the general population, and that can affect cognition as well. So in older adults, they may have less typical symptoms of depression. It may be irritability and poor sleep more than like actually feeling what they would identify as depressed or feelings of sadness. Next slide, please. So quality of life concerns in older adulthood are already a big issue before you even factor in epilepsy. Lots of independence, driving ability, worrying about falls, cognitive decline, or worrying about cognitive decline are big issues. And we know that seizures, depression, and additional medical diagnoses are only going to worsen quality of life. Quality of life measures for people with epilepsy found poorer quality of life for older people with epilepsy compared to younger people. And it was slightly worse if they were recently diagnosed, and it was felt that was probably related to the fact that there's been less time to adjust to the diagnosis, possibly also directly related to not being able to drive. Next slide, please. Isolation is a big concern. 17% of older adults with or without epilepsy are in touch with family, friends, and neighbors less than once a week. About half of people 75 and older live alone. And with seizures, there can be a loss of independence, an increase in anxiety and depression, and then like with all adult age groups with epilepsy, driving can be limited by seizures. And that has a huge impact on quality of life. Next slide, please. So how can providers like me and like your neurologists support older adults with epilepsy? Listening, I think I suspect the biggest, most important thing we can do so that we're really understanding somebody's experience at home with their medications and living with epilepsy. Like I said before, good communication with people's other physicians, especially their primary care doctors, and also with pharmacists. Another thing that can be really helpful is just making sure that people have a plan for what to do if and when a seizure happens, when to call 911, and if they need a medication at home to use specifically when seizures happen, to provide that, and then to support or to provide that additional support and education at visits. Of course, you have all found your way to the Epilepsy Foundation. The other thing is just for me, I think it's important to be aware of people's financial considerations, because Medicare Part D plans can be very confusing and also very expensive in terms of out-of-pocket costs. And to also make sure we're assessing for any mood concerns, because they're treatable. We know they're more common in epilepsy, but they're just as treatable as they are for anybody else. Next slide, please. Safety, I will just say, it's an important conversation to have with your providers around bathing, baths versus showers, driving, falls prevention, and then sometimes a seizure detection device is helpful, especially for people who live alone. Next slide, please. So what can you if you are an older adult living with epilepsy or a family member, what can you do? Is I would just encourage you to be in good communication with your clinic. If you have questions, if you're experiencing side effects, and also if you're having seizures. I always feel kind of bad when people come into appointments and they've had a lot of seizures, or they're feeling poorly on their medication, and they felt like they had to wait until the appointment to let me know about it, because I want to hear about it if it's happening. So get on the horn with your clinic if you're having anything that needs discussion. Don't wait for your appointment. Use a pill organizer, set alarms if it's hard to remember. If you need help with medication setup, whether that's another set of eyes or a visiting nurse, something like that, just ask for it. And then if other people reach out to family or friends, let them know that you want to see them and if you need support. And it can be hard to ask for that kind of help, also for transportation, but just ask. And then, like I said before, video can be really helpful. And I'm going to skip my last slide, which is specifically about skilled nursing facilities, but if people have questions about that, they can let me know. And then my next slide after that is just my references. And then after that, I just listed some resources. The CDC has a good website for older adults with epilepsy, Epilepsy Foundation, obviously. And then there's something called the Hopscotch program, which is a cognitive epilepsy self-management program that can be helpful too. So if you want to Google that, it's Hopscotch, and it's through Dartmouth. Okay, I realize I talked more than I was supposed to, and I want to try to answer some questions. So Debbie's going to read them off to me.
Sure, that's great. Let's start with the first one. Can epilepsy cause dementia later in life for middle-aged and younger adults? I know you talked about
the other way around,
dementia causing epilepsy, but what about the other way around?
I wouldn't say it can cause dementia, but it can cause chronic memory problems, especially for example, for people who develop epilepsy earlier in life, and it involves the temporal lobes in particular, and especially if seizures are not controlled over one's lifetime, there can be very chronic memory impairment, although dementia isn't necessarily the technical term that a physician or neuropsychologist would use for that. But it doesn't increase your risk for Alzheimer's.
Okay, good to know. Next question, can epilepsy, oh, wait a minute, I already answered that one. Let's get this one. Can hitting your head often and hard cause seizures? And what about anxiety and depression meds? And I think you addressed the fact that the anxiety and depression meds can be a problem.
Hitting your head often and hard can, if it's causing bleeding in your brain, yes, absolutely, it can cause seizures that way. Otherwise, if it's a question of concussions, like multiple concussions over time can increase the risk of seizures. The kind of head injuries that are most likely to cause seizures in epilepsy are seizures where there is loss of consciousness lasting for minutes or longer, or head injuries that cause bleeding inside the head.
Okay. And you did say that anxiety and depression meds can be a factor.
They can be a factor, and certain ones cause seizures much more frequently than others, but many medications in those categories can. So if you have a question about something you're taking, just run it by your seizure physician.
Okay. You mentioned low sodium being a metabolic cause for seizures. Any thoughts what to do if you have high blood pressure and hyponatremia, in particularly if have hyponatremia due to the seizure medication, trilaptol?
Oh, yeah, trilaptol is one of the seizure medications that is kind of notorious for being able to cause low sodium or hyponatremia. I feel like I can't answer that question too well just because I don't manage blood pressure, but I would say internal medicine doctors would want to look for blood pressure medications that don't also lower sodium levels. So like beta blockers, for example, or calcium channel blockers. So there are some different approaches that would be less likely to make that problem worse when you already have it.
Okay. You had mentioned cryptogenic epilepsy, and this person wants to know, is this hidden epilepsy? Is it called that due to the cause being unknown?
Yes. Yeah. Well, cryptogenic or idiopathic. I think what we're learning more and more, especially with the, advances being made in genetics and so on, is every epilepsy has a cause. We just don't know how to identify all of them yet. So there is some kind of underlying cause, and it may be genetic, but involving many different genes and environmental influences. But it's just basically saying that the medical field has not caught up to those combinations or causes yet.
Okay. Does marijuana withdrawal also make you more prone to have seizures? You talked about alcohol.
I don't think that it does. Looking at marijuana, there's a lot of information about it, a lot of study about marijuana and epilepsy, and we think probably CBD, for many people with epilepsy can have a benefit in terms of seizure control, but we also like studies looking at the THC part of marijuana in like animal studies that I think involve rats could provoke seizures. So like actually having marijuana, depending on what it is and depending on you as an individual, could be good or bad for your epilepsy. But I don't think that there's a phenomenon of marijuana withdrawal causing seizures.
Okay. We are getting really close to the end of our time, so there are a couple of questions on here that I believe that we at the Epilepsy Foundation would be able to answer, and I will reach out to these folks individually with answers to those questions. Particularly around calling EMS and around seizure tracking devices. There are one or two here, though. What causes a meningioma to develop after a temporal lobectomy?
After a temporal lobectomy? Oh, that's a good question. Because generally we think meningioma is mainly, and that's the kind of benign tumor that grows from the meninges, which is the lining of the brain. That is just bad luck, essentially, like most tumors. So I don't know for sure if after having a temporal lobectomy, I do not know the answer to whether having had a prior brain surgery that would have, cut the meninges, cut the dura mater, whether that increases the risk of developing that kind of tumor in the future. I don't know whether there's a risk there or whether it's just being unlucky.
And then you had mentioned epilepsy improving with menopause. Do hormonal changes cause seizures in ages 65 and up?
They don't tend to, just because hormones tend to be more stable during that period of one's lifetime. There tend to be fewer ups and downs, and for men in general, there are not a lot of hormone fluctuations after, puberty and adolescence. It tends to be that the hormonal fluctuations that tend to influence seizures are really around the kind of menstrual cycle in women, that estrogen and progesterone cycle. So I think it's pretty uncommon to see seizures related to hormones in older adults unless they're on estrogen potentially, or on and off of estrogen, or on high dose estrogen.
Okay. All right. Well, we do still have a few questions, but I want to let everyone know that you can reach out to us directly here at EFMN, and I'll give you some information. Just real quickly, Dr. Hanna, thank you so much. I just have a few slides I want to go through. This is our mission statement here at EFMN. Again, you're going to have this, everyone's going to have this PowerPoint. You'll be able to read that for yourselves. Client services was what I really want to mention just quickly. We do provide free one-on-one support. So you can call us, you can reach out to us by email. The easiest way to reach out is through our website at this address here, efmn.org/information-services. Whatever your questions are, the questions you've already asked here, you can reach out to us with, as well as any other questions related to epilepsy. And we really try to work with people individually to give them the customized tools and resources that they need to get their questions answered. And that may involve us answering your questions. If we don't have answers, it may involve finding those answers for you or referring you to other organizations that can help. So please don't hesitate to reach out to us with your questions. I want to thank our sponsor again, Synovian. I want to thank Dr. Hanna for being here tonight. I want to thank everyone who attended. Our next Wellness Wednesday webinar is going to be on testing and tools in diagnosing epilepsy. You had talked about some of those things like EEGs. We're going to get into more depth about what those tests are, what they show, and how they're used in diagnosing and treatment. That will be on June 21st, and it will be with Dr. Elaine Worrell from Mayo Clinic. So again, thank you all. Dr. Hanna, thank you for sharing your expertise. This was really interesting and very helpful, I hope, to the folks who were in attendance.
Well, happy to be here, and I'm sorry I can't see all of you out there, but thanks so much for coming, and I really enjoyed being here.
And again, thank you all for attending, and I hope everyone has a great evening.